Hello, welcome to my YouTube channel. Today I'll be discussing about pulmonary embolism, which carries a great significance in step 2 CK, and I'll be going through its high yield facts quickly. So, if someone presents to you with pulmonary embolism, what symptoms will they have? Usually, they might be having shortness of breath, which will be sudden in onset. So, if someone presents to you with acute, sudden shortness of breath, chest pain, and fever following a surgery that occurred 2 days ago. So, the first differential that should hit your mind is pulmonary embolism. Now, there is a modified Wells criteria for the probability of having pulmonary embolism if it's more than 4. So, it denotes that pulmonary embolism is likely to be there, but again, that has to be confirmed with certain diagnostic tests. So, first of all, remember the modified Wells criteria, that is very high yield to remember. Okay, it should be more than 4 to go for a diagnostic test. So, 3 points, it's divided in this way 3, 1.5, and 1. Okay, 3 points for any two of the following, which is if the patient has clinical signs of deep venous thrombosis, or if alternate diagnoses are less likely than pulmonary embolism. Okay, so if 3 point to any one of these, if such features are present. Then 1.5 points to any 3 of these if the patient has a history of previous pulmonary embolism or DVT, if he is tachycardic more than 100, or if he had recent surgery or immobilization. So in our scenario, he had recent surgery, so 1.5 points for that. And 1 point for either hemoptysis or cancer. So if you're gonna calculate according to this criteria and you get it more than 4, that will make you go for CT pulmonary angiography. Okay, if the patient does not have, like if it's less than 4, then you have to go for D-dimer testing. If the D-dimers is more than 500, then you're going to go for CT pulmonary angiography. Okay, and if that diagnoses it, so yes, pulmonary embolism is diagnosed. Okay, so I'm just going to quickly repeat. If someone has a modified Wells criteria more than 4, you have to go for CT pulmonary angiography or VQ scan. If that confirms pulmonary embolism, you have to continue anticoagulation treatment with either thrombolysis or surgery, depending on what the situation is. If someone has Wells criteria less than 4, scoring less than 4, so you have to go for D-dimer testing. D-dimer, if it shows more than 500, so then you're going to go for diagnostic testing, which is CT pulmonary angiography. So CT pulmonary angiography is a diagnostic modality. Okay, and then it would further show that whether the person has pulmonary embolism or not. Now, if someone presents to you with the features that I just mentioned previously, right, like acute shortness of breath, periodic chest pain, fever, atrial fibrillation, if someone presents like that and you do suspect them to have pulmonary embolism, you first have to make sure stabilize the patient. If the patient is hemodynamically unstable, you have to stabilize the patient, and you need to also make sure that you carry out transthoracic echocardiography, because pulmonary embolism is associated with right ventricular dysfunction. So if someone is presenting with hemodynamic instability, like if they are presenting with shortness of breath, chest pain, and they are hypotensive or they're tachycardic, okay, so they are in a state of shock, so at that moment you have to also go for transthoracic echocardiography to look for right ventricular dilation or hypokinesis. Okay, so that would show that right ventricle is impacted. So I was going through the uh, management of pulmonary embolism. So yes, if someone presents to you with that, okay, and you suspect a person having pulmonary embolism, you have to make sure that they have no contraindications to anticoagulation, which can be either hemorrhage or recent surgery, okay, or any coagulation disorder. So you need to make sure they do not have any contraindications. Okay, if they do not have any contraindications and if you suspect pulmonary embolism in that patient, you're going to start with anticoagulants before carrying out diagnostic test. Okay, what was the diagnostic test? CT pulmonary angiography. So you're going to start with anticoagulants preceding CT pulmonary angiography or VQ scan, and then depending on the result of CT pulmonary angiography, if it's positive for pulmonary embolism, you're going to stop. You're going to continue the anticoagulants and then go for further treatment like surgery or thrombolysis. If it's negative, you're going to stop anticoagulants. Okay? And if patients who have contraindication to anticoagulation, so you're going to directly go for CT pulmonary angiography, and if it's positive, so then you're going to go for IDC filter. So please remember that. Okay, apart from that, you should know that what is the most likely risk factor for patients having pulmonary embolism who are hospitalized. The risk factor is obstructive shock and age. So please remember that. So age and obstructive shock are the most important risk factors for pulmonary embolism in patient mortality. And other risk factors for like 30-day mortality includes hypotension, like SBP, systolic blood pressure less than 90, tachycardia, tachypnea, hypoxemia, altered mental status, history of cancer, age more than 80. Okay, and also one more thing, if someone has a contraindication to IV contrast or cannot undergo CT pulmonary angiography, then you're going to go for VQ scan, like in pregnant patients. And also remember the management that if you have to give anticoagulants, unless there are specific contraindications to anticoagulation, inferior vena cava is indicated if someone has contraindications to anticoagulation. Thrombolysis is indicated if someone has pulmonary embolism with hypotension. And embolectomy, whether percutaneous or surgical, is indicated when the patient has shock and he is very hemodynamically unstable or who have had a failed thrombolysis. Lastly, patients with acute pulmonary embolism can also present with syncope because of right ventricular dysfunction. Okay, and as you know, that pulmonary embolism prevents the right ventricular outflow of blood by blocking the blood flow to enter into the pulmonary arteries. So the blood backs up in the right ventricle, right atrium. It can cause jugular venous distension. Okay, it does not go to the left ventricle, so the cardiac output decreases, and that can lead to syncope. And it can also present with mild atelectasis or bloody pleural effusion. And lastly, if you have to differentiate myocardial infarction from pulmonary embolism, right ventricular myocardial infarction will present with bradycardia or arrhythmia, and pulmonary embolism will present with dyspnea or syncope. I hope I made that clear. Oh, okay. Good luck.